problema na ako dyan. Kasi descriptive pero wala tatap. Pero maganda sana.
Fundamental to the genesis of chronic pain is central sensitization, a constellation of changes in spinal excitability. Minimizing perioperative pain is essential to limit the magnitude of physiologic wind-up and prevent chronic debilitating pain. Chronic post-mastectomy pain can be physically and psychologically overwhelming for breast cancer patients. Though epidural and paravertebral block has been used to block surgical nociceptive input and prevent chronic pain after breast surgery, these were difficult to perform and has reported complications. Erector spinae plane block, a novel fascial block described to treat thoracic neuropathic pain, has been recently used for other indications because of its simplicity and safety. Good morning, doctors. The title of this case series is Prevention of Central Sensitization by Using Erector Spinae Plane Block for Breast Cancer Patients Undergoing Mastectomy. The objective is to present the initial experience of using a single-shot ultrasound-guided erector spinae block as part of the multimodal analgesia regimen in breast surgery patients, aiming to prevent post-op central sensitization by reducing pain scores and opioid requirements. This was a case series of 3 conducted in a tertiary hospital in the Philippines. The first 3 patients selected were ASA class 1 or 2, aged 18 to 70 years, and scheduled for any breast cancer surgery. Explanation of the technique was done and written consent was obtained. In the block room, all patients were attached to ASA monitors, received mild sedation and oxygen. Patients were positioned prone or lateral to ensure comfort. Counting down from the spine of the 7th cervical vertebra, the spine of the 4th thoracic vertebra was identified and marked. A linear probe was placed longitudinally across T4 spinous process and was moved laterally to the side involved in the surgery to identify the T4 level. Probe was positioned to get a good image of the hyperechoic T4 transverse process and the 3 muscles of the posterior thoracic wall, namely trapezius, rhomboid, and erector spinae muscles, were identified. Note the location of the transverse process as well as the pleura. Under aseptic conditions, a 22-gauge 50mm block needle was used in plane in the caudal to cranial direction until the tip contacted the T4 transverse process. Shadow of the needle shaft was shown by solid white arrows, while local anesthetic lifting the erector spinae muscle of the transverse is shown as solid yellow arrows. Here is a clip in one of our patients given ESP. Note the entrance of the needle from the upper right corner from caudal to cranial, targeting the transverse process. Needle shaft can't be seen clearly, and we rely on needle movement and shadow. The needle hits now the transverse process, and note hydrodissection with plain NSS to confirm needle tip position, followed by the local anesthetic lifting the erector spinal muscle of the transverse, distributed in both cranial and caudal directions. After the block, patients were then placed in supine and transferred to their assigned theaters for GA induction. We operationally define prevention of central sensitization as adequate post-operative pain control, and the following were assessed: pain intensity on the post-operative site, complications, and the total tramadol consumption during the 24-hour post-op period. Case 1 is a 52-year-old with controlled hypertension, weighing 70 kilos with a BMI of 28, for sentinel lymph node biopsy, and total mastectomy left. Pre-op, a left ESP was performed at T4 with 20 ml of bupivacaine 0.25% and had general anesthesia. Intra-op, no additional fentanyl was given. At the PACU, patient had an NRS of 0 out of 10, both at rest and upon abduction of the ipsilateral arm. Post-op, patient did not receive additional opioid and had no incidence of nausea and vomiting and was discharged 20 hours post-op. Case 2 is a 57-year-old with controlled hypertension weighing 48 kilos with a BMI of 21. 4 MRI bilateral with axillary lymph node dissection left axilla. Pre-op ESP block was done bilaterally at the same level with the same local anesthetic dose. No additional fentanyl doses were given intra-op. At the PACU, patient had an NRS of 0 out of 10 on the right and 1 out of 10 on the left breast at rest, NRS 1 out of 10 on the right and 4 out of 10 on the left breast upon abduction of arm. One dose of 50 milligrams tramadol IV was given with relief with no nausea and vomiting during the whole post-op period, and patient was discharged 36 hours post-op. Case 3 is a 62-year-old with controlled hypertension weighing 80 kilos with a BMI of 31 for MRM right. Pre-op ESP block was done, but unlike patients described previously, block performance was challenging due to difficulty in visualization of the needle and transverse processes. However, intra-op, no additional opioids were given. At the PACU, patient had an NRS of 0 out of 10 at rest and 3 out of 10 upon abduction of arm and verbalized numbness on the mastectomy site. No incidents of nausea and vomiting and no rescue medications were noted as well. Patient was discharged a week after since she has to undergo another procedure. Table 1 shows the summary of the demography, type of surgery, intra-op and post-op opioid consumption, pain scores at the PACU, and complications. In all 3 cases, ESP was effective in minimizing opioid use and reducing the incidence of unwanted side adverse effects. However, in radical mastectomies, where axilla is involved, pain scores are higher, though acceptable, especially during abduction of the arm, which could be due to inability of the local anesthetic to reach the T2 level. Note that one patient is obese, where there is difficulty in block performance, secondary to difficult visualization of structures. But then, no complications were noted. Surgical nociception results in post-op hyperalgesia via pro-nociceptive changes in CNS processing. Such central sensitization occurs via 2 mechanisms, namely damage to tissues, damage to nerves, and these have been linked to the subsequent development of persistent pain. Regional anesthesia blocks the conduction of impulses along the nerves and minimizes the transmission of signals, possibly preventing central sensitization by preventing the nociceptive inputs into the dorsal horn. According to Lopez, in ESP, local anesthetic diffuses to the dorsal and ventral rami, achieving an extensive multidermatomal sensory block. According to Chin, injection of 20 ml of local anesthetic into the ESP produces spread that extends at least 3 vertebral levels cranially and 4 caudally from the injection site. However, some authors refuted these findings and different understanding of its mechanism. Despite the reported differences, ESP block has been reported in case studies to provide good analgesia and decreased opioid requirement, which are consistent with our findings. ESP block is an attractive option as part of the multimodal regimen in breast cancer surgery patients. Its goal is to prevent post-op central sensitization through reduction of opioid requirements while providing good and acceptable post-op pain control in post-mastectomy patients. Recommendations include to do a study with more subjects and to do a follow-up months or years after the surgery to assess the symptoms of central sensitization and evaluate the incidence of post-mastectomy pain. Thank you.
So I'd like to congratulate you for having that skill and expertise on doing ESP block on your patients. Not all trainees can have that kind of skill, you know. But then your presentation is a descriptive research study. What you should have done is that because as early as year 2000, this ultrasound guided peripheral nerve blocks have started already with reported results from the developed countries. Because we belong to the developing countries, it's only now that we are performing all this ultrasound guided. So, what I'm driving at is that we should have because I have read a certain presentation like yours, wherein the author collected a series um, of successful procedures like yours, and then he did a meta-analysis. Maybe in the near future, you have to collect some more as your
Yes, ma'am.
recommendation says so.
Actually, ma'am, this technique has just been discovered 2016. So, RCTs are few, only 2 from mastectomy patients, and the rest